Okay, well, start the webinar.
Yeah.
All right, well, welcome to everyone. I'm excited that you guys could be here today. We are doing a webinar today on alternate medical opportunities. I know we have some other people that are trying to join us here. Let me see if I'll get them hooked up as soon as they come on. But in any case, we just wanted to kind of go over some things to get you guys up to speed. I know right now that we have, Laurie Wallace with Life's Journey Hospice. We have Molly Deaton with Profound Health Solutions. I know we have some others that are trying to join here. We'll let them on if they get here. I'm just taking a peek look here real quick. So in any case, here we are. So what we're really wanting to talk about today, I know we had a couple people at the last second that had to bail, and I will kind of let you guys know that why I wanted them here is because they also bring some different services. One was Zach Niehaus with Dispatch Health, who I have personally used for my family here in a few times in the last month, where they will come. They're kind of like a emergent care, not emergency care, but like a doc in a box type environment where, like a med check, but they come to your house to do it, your office to do it, what have you. So there's an advantage there. And I wanted to have them mentioned on here. Also, I know another one that couldn't be here because she had had oral surgery all of a sudden at the last second. Emergency oral surgery was Teresa Patterson with Genesaret, which is a free clinic. Hi, Tina. I see Tina has arrived. So how are you?
Well, thank you.
Good. So I'm just going ahead and we have Tina here with Baxter Professional Services. And since we'll just go ahead and let you start introducing yourself and what you do and the scope of services that you provide. We'll just start right there.
Okay, great. So my name is Tina Baxter. I am a nurse practitioner. I'm working with Adult and Child Health in Indianapolis, and I also have Baxter Professional Services. And we provide, at Adult and Child, we provide adult, adolescent, and older adult services. So if you're needing services for dementia, mental health services, that type of thing, that's what we're here for. We also have primary care. And then for Baxter Professional Services, I help provide legal plans and identity theft protection to individuals, families, and small businesses. And I can help you get your wills done. And it is Will Month. So it's a National Will Month. So we're out to promote getting your wills completed, your medical advance directives.
Well, very good. So, Laurie, tell us who you are and what you do.
I am Laurie Wallace, and I am also a nurse practitioner, and I have alphabet soup of certifications. I'm also a certified dementia care specialist and adult geri nurse practitioner and acute care nurse practitioner. But my specialty, I'm also certified in hospice and palliative care, and I own and operate Life's Journey Hospice, and we do some palliative care too. And we have a 20-bed inpatient facility that's unique in the country, one of the first that integrates all hospices and allows everyone to use our facility for respite, general inpatient, and residential hospice services. So.
Well, very good. And let's see real quick. I'll get my brain working here. Molly, tell us who you are and what you guys do.
Thanks, Jim. I'm Molly Deaton, and our company is called Profound Health Solutions, and we provide health education programming from a chronic disease prevention standpoint. Our program is the nationally recognized by the CDC, Medicare approved program for Medicare diabetes prevention. And our largest client that we're serving is our geriatric population and independent living sector, and also retirement communities.
Well, very good. And well, tell me what does that mean? What are you doing when you're there?
We actually run a 26-session lifestyle modification program, and inside of each session, we concentrate on educating them on options that they have available to them for better health outcomes. And really, that's what it's related to. All the topics are related to insulin resistance and what lifestyle modifications we can make, no matter what our age is, to help enhance our health.
Well, very good. Well,
Did,
go ahead.
did I answer your question fully?
You did, I believe so, yes.
To actually reduce like chronic disease risk factors.
So Laurie, you run a very unique community as well. Okay, so kind of go into little details about what you're doing and what you're bringing to the service here that others are not getting a chance to do.
Right now, well, our whole model was focused, and it was a dream I had that all hospices should be able to come together and provide a place that is hospice, the comfort of hospice. It's a home-like environment, but yet it's an inpatient facility where all these hospices can put their patients for different levels of care instead of having the traditional options of hospital or nursing home for that care. We are hospice experts. It's a very unique concept. And actually, we just had a surveyor tell us that we are the only, and she's done hundreds of surveys, that we're the only place she's ever seen such success with integrating, working with other hospices, even though we have our own hospice as well. We have our own home hospice, but we're not a competitor. We feel like everybody should be playing in the field together. We also do palliative care. We have contracts with 33 hospices to use the facility. And we offer, the different levels of care hospice provides for that. But with the palliative care, we do some palliative care at home, and we actually have a couple of people that reside here in the facility receiving palliative care. So those are kind of the unique things that we were kind of bringing to the table. We're actually looking to expand and build another facility on the north side of Indianapolis, and we are in the works with that right now. So I'm excited about that, hopefully to bring this unique kind of service to that area as well. We specialize just in hospice. So when a patient comes here that is a hospice patient, that's what they can expect to get, is a full hospice experience. And we feel like that it's been really successful. It's taken us several years, 3 years. We're on our fourth year, and it was a hard concept to grasp at first, but everybody's starting to understand what we are and who we are and why we do what we do in that realm. So we're offering some unique different types of services like that. I, as an MP, I go into facilities and will help do end-of-life training and end-of-life dementia training as well for those facilities. So it gives them a resource as well for extra education for their staff to understand more about hospice and how to recognize patients that are on hospice, or how to recognize patients, which is what we're going to be talking about today, is palliative care. How to recognize what deems as palliative care, and how someone qualifies for that type of care as well.
Well, let me ask you a question. I know that you're very unique in the fact that you provide space, and then whether other competitive hospice companies can use that space with their clients. Have you had a lot of pushback in the industry because you're so different? I mean, are they afraid of you, or Yeah,
at first we did. We offered. What we do is we offer guaranteed. I'm not here to take another hospice company's patient. I tell the hospice community, even patients as well, we're not here to change. The whole reason for my dream, for my business plan, was that they wouldn't lose those people, because often a hospice patient would need to go in a hospice facility, but they would have to revoke because that hospice that they were on did not have a facility. So they would have to lose the team of people who've been caring for them, who knew them, who have developed a relationship with them, and have to go to a new hospice company because of the use of their facility. So at first it was a hard concept to grasp. It was, but they all learned to trust, and I think building trust and just guaranteeing them, I'm not here to take their patient. We've had some patients that have transferred, but we have deep discussions of why. But that's not something that happens. It's maybe, just a couple of times in 4 years. So, but that's not our goal. Our goal is to keep them intact with the hospice company that they're using, so that relationship stays intact. End of life, we don't have much time to make an impact, and we really need to make sure that impact is good. And we don't want people to have to go through different caregiving entities, agencies, and caregivers themselves. It's very confusing, and it's hard enough to be in your last days as it is, let alone to have that kind of confusion. So we don't, we want to just ease that confusion and just offer this space. But now that we have these relationships, Jim, actually, the other hospice houses are starting to copy what we do. So they're
There you
trying
go.
to get on board as well. I feel like imitation is sometimes the best flattery. But I do feel like, you know, we definitely, that was our whole vision, ministry. This is our ministry. We think of this as a ministry. We're very faith-based. We're not faith affiliated, but we are faith-based. And we feel like, you know, we have to do our best as a community. Any healthcare community should come together and make sure the patient's given the best level of care possible in the best place possible with the best people possible. And sometimes that may not be Life's Journey. That may be somewhere else. We help get people to where they need to be. If it's not, if they need a different type of environment, we want to work with everyone. And I know it sounds like kumbaya and eat in the Garden of Eden, but that's really what our goal is and our vision is. We want this relationship of partnership and community in the end of life industry, because we're often thought of as the ugly red-headed stepchildren of healthcare anyway, because nobody really wants to talk about hospice care. And it's very confusing to understand hospice and palliative care. They are very much like sisters. They are related, but they're very much different as well. So I'm glad you were having this today.
Well, thank you. I was going to say, anyone that's first time through with a new concept is usually going to get their nose bloodied a little bit in the process. So.
Oh yeah, we've been getting beat down for a while, but it's starting to come around. So the people that use us religiously. So
well, it's good to see that people have the courage to make the changes that help everybody. So, Farah, welcome. So we finally got our connections connected here. So introduce yourself and your office and what you do and all that kind of stuff. We'll bring everybody up to speed on you. We're getting no sound. There we go.
You're muted.
Well, that's the like saying of 2021. Your mute off, right? So my name's Farah Myers. I'm a family nurse practitioner and I own a private practice. So I do primary care. What's different about me is I do direct primary care. So direct primary care, the model itself is essentially what we call kind of like membership medicine, or another way people are very familiar with concierge care. However, this is an affordable form of concierge care and you don't really need to have any type of insurance depending. And, you know, I serve all levels of insurance, essentially. No insurance, high deductible plans, fully insured. So what we do is for a monthly membership fee, all of my services included, including time, direct access to me, 24/7 access, if they can text me, call me, email me, all of that. And then, and I include a lot of services within the membership fee as well. So point of care testing, your strep test, your flu test, EKGs and all of that. And then I have discounts for lab pricing as well. So what we do is we just provide full service primary care and try and make it as comprehensive as possible with extended appointment times and same day availability. So
well, I've been hearing about this model starting to spread across the country. So it's a very new thing, but I think a lot of people don't know, you know, that it exists or how to access it, or, you know, who's doing it, you know. So, you know, I don't know how many there are here on the north side that are doing this kind of stuff, or across the city. So, you know.
Yeah, there are a few that are doing it. I am the only nurse practitioner that's doing it. There are a few physicians that have the model as well. But yeah, I'm the first nurse practitioner to start. There's actually one right down the street, a physician that works as well doing direct primary care. But yeah, I mean, she's getting filled up and we've been busy. So it's been good. It's just been a great way to provide really comprehensive care for patients. And it allows them to have the time instead of, you know, when I was working in the traditional insurance-based clinics, I was spending like 8 minutes with a patient on average. And really that's not enough time to provide comprehensive primary care. Things were getting missed, you know, even just simple things as far as like realizing maybe their diet needs some changing. Maybe we need to discuss a little bit more in depth about exercise, lifestyle choices, lifestyle habits. I can do that with people here. You know, most of my appointments last from anywhere from 45 minutes. Our intakes are generally 90 minutes. So I get to know my patients really well. And I do everything. I do the lab draws, I do the vital signs, all of that. It's amazing the amount of information that you can glean from somebody and how you can connect all of those dots if you just are able to spend the time with them.
Well, that is an area that I know just from personal experience that in most cases you do not get. I think I heard national average, you get 6 minutes with the medical professional, which, you know, you're sitting there and you got your little list and you're trying to make sure you don't forget the 14 million things you wanted to talk to them about. We just had an appointment with a family member that we were trying to get coordinated, having all kinds of medical issues. And this gal was a specialist that works on that particular, in Parkinson's. And we get in there, we got the 6 minutes, and we notice in the notes later that my loved one was had the highest prescription of this particular drug that this person has ever seen, but she did nothing to change it.
Yeah.
So we've had to go back door and get things done. It's really an asset to be able to have a moment
Sure.
to talk, and take a breath, rather than trying to figure out how fast you can talk.
And what's really been fun is that with my patients, it's like it might be cheesy to say, but it's like they're not only just my patients, they've become my friends, and so like I had one lady who we were talking and all of a sudden she's like, oh yeah, I have chickens. I'm like, you have chickens? I was like, I love chickens. And she's now my egg lady, and so it's very cool to be able to have that relationship with them. And I've noticed a huge impact on patients when they're able to learn more about me. That makes them more open to tell me everything that, could be pertinent to their medical health and everything. So it's more like, taking medicine back to its roots, to that old town family, family provider that very well and that knows kind of the idiosyncrasies of your health. And so it's been a lot of fun. It's very fulfilling for me, but my patients have been, they love it. So.
Now, you said something at the beginning that I want to ask a real quick question on. You made a comment that you take all levels of insurance, no insurance to different kinds. So it really is a blend.
Yeah, I mean, it's really, I have a blend of people. So the folks that are not insured within the membership fee, I also include your annual physical lab. So you don't pay extra for those. And then, so like, for example, lab tests, I have a full wellness panel that I do. And when I went to go get like my B12 checked and through my insurance, I asked, I went to IU Health and I was like, hey, how much is this going to cost me? And I went through my insurance and they said one lab for B12 was going to be $125 billed through insurance, and insurance may or may not cover it. I do a B12 for $9. So the markup on labs is extraordinary. Even these other cash pay lab places, it's just, it's still, they mark it up so much because they can. So I don't do that, I feel like it's like a Costco membership or something, where it's like, you're a member, you get my discounts. And so I push that all to my patients, but I also want to make it so that they don't feel like they're getting charged for extra things just because they think I'm that we're racking it up or anything. So I keep the prices very transparent. So that's really great for people that obviously have no insurance, but they can still get great medical care. And also for people that have the really high deductible plans that they never meet. So when you bill insurance for things, the hospitals will bill at a higher rate because that patient is insured. But if you go in saying your cash pay, there's still a high rate, higher than what I charge. But it's a lower rate if you can pay cash in full. And so just think about that for a second, that if you're never meeting a deductible and you're still paying insurance rates, why do it? So within this, you do a monthly membership fee. That's a steady fee across, and it budgets your healthcare dollars. And then we can do your labs a la carte, however you need to do it. And you're paying a lower rate. You may not put it towards a deductible, but if you never meet it, what's the point?
Well, I was going to say a lot of independent contractors, have very high deductibles and things like that. So
so we work with. I have a lot of patients that are small business owners that have had the catastrophic insurance, but they just don't get the preventative care covered, that kind of thing. We cover 80 to 90% of your healthcare needs in primary care. Why don't we make that accessible to people?
Yeah, I was going to say I had some friends that were on Obamacare and it was like a $12,000 deductible, so they're never going to get anywhere near any benefit from that. So well, Tina, tell me about you and what's going on and how who do you serve and what do you do for people?
Well, what I do, if you're coming in to see me in the clinic, then I work with older adults with chronic mental illness. So those that have depression, bipolar disorder, schizophrenia, whatever, we can see you and take care of you. And I will say that what a lot of people think is that, well, suddenly you turn 65 and you don't have those problems anymore, but yes, you do. And so I help manage some of that and coordinate care with your primary care, because a lot of times they'll start medication and maybe you're on a heart medication, but it interacts with your psychiatric medication, but you've been stable psychiatrically for a very long time, or maybe you've been on a medication that was working for you psychiatrically, but now your body cannot metabolize it as well. So we may need to make some adjustments. So I encourage people that, make sure that they stay in close contact with their providers that are giving them their psychotropic medications, because, things change over time, newer medications come out, but they may not be able to metabolize things like they once were. So that's kind of what I do. And then again, I mentioned the wills through my other business, through my own business. We're helping people to get their wills completed in their medical advance directives at an affordable cost. And that's what we try to do, is to help people. So I have a will workshop coming up on Saturday.
Excellent.
Mhm.
Well, make sure to go into this Facebook thing and put a link to where it's going to be or something. So
Yes, I
have
will.
people find you.
Mhm.
What the mental health situation? I mean, we are dealing with a major crisis in that area at this
Yes.
point. So now, are you seeing people only in your office? Do you go to? I mean, how does that work?
Well, for right now, I'm office based, although we are doing still some telehealth and telemedicine, so you can get an appointment on the phone. And so for some of our older adults that maybe can't get out or are afraid to get out because of the pandemic, we do still offer those telehealth services.
Okay. So now, is it a situation? Because I think you and I've talked before on this, and there's situations where there's a client that all of a sudden is getting ready to be kicked out of a assisted living because of acting out in certain ways or whatever. It may end up being a medical issue, or as far as drug interaction or what have you with their meds, doing something to their mental health.
Mhm.
I know that you're involved sometimes in helping these people get to where they can stay there. Because I remember you telling me stories about a lady that was getting kicked out, and and that you've been able to help. That I think is a real crisis. I do hear about that a lot, where all of a sudden someone, was saying they've got a family member with dementia, for instance, and also they can't find a facility because of some of the acting out. What do you get involved in helping there, or do you have resources that you would send people to, or how does that work?
We have community health workers that are here, and they can help them find a placement for someone. They can help. There's a lot of referral sources that we work with. So for instance, I had a client that was really struggling with living on his own. And so he had schizophrenia, but on top of that, he had developed a dementia that almost went unnoticed until he was doing things like going to his neighbors' homes and banging on the door and asking them to call the police because he was worried that something was happening to his brother. And he wasn't sleeping. And then he stopped taking care of himself and cleaning his apartment, and all that stuff started happening. And for a long time, he'd been really stable on his psychiatric meds, but it was masking some of the underlying dementia. So we were able to get him placed into a facility because he had gone that far, that he had to have placement because his brother was no longer able to take care of him because his brother was diagnosed with cancer. So we were able to help facilitate getting him into placement.
So I was going to say, I know that I personally had an experience with a family member that went through a depression, was then given antidepressants, and during the time frame that they were interacting, they hadn't really kicked. They told us it's going to be like 6 weeks before it really did anything. Oh my gosh, it did things. It just didn't do good things. It had him totally paranoid. He was running away from home. He had all these theys that were out to get him, that were all drug related action. And I don't think people really know these things. I'd gone 60 some years of my life and didn't know any of this stuff, and all of a sudden we're having to deal with it. Right. So what, you know, and this, anybody else wants to weigh in on these things, you can. I mean, as far I know that you're dealing with people as well, you know, please jump in to fill in blanks here. But what do we do for folks that are in these circumstances? I know this as a family member, we were in panic mode trying to figure things out and really struggling finding resources that could help us. You know, there's very few beds in these facilities there. You know, it was, you know, at one point we were actually told by the psychiatrist that he would only allow him come back if he would have if we'd allow electric shock therapy. We're going, wait a minute, you know what? You know, and so it was, you know, as it turned out, we had a meeting to talk about it, and by the time we had the meeting, they said he didn't need it. But as a consumer out here dealing with a family member and not knowing what you're doing, you know, and we need your voices to tell us stuff that's available. So that's really what I'm looking for there. I'll let you guys figure out how to decipher that question, but yeah.
Well, I can kind of speak for that. Just, you know, part of that is that we have a lack of availability to our prescriber. So really what you should have been able to do is go back to the prescriber and say, this is what's going on. And they would have been like, stop the meds immediately, you know, or switch to something else, or let me get you in really fast. Unfortunately, we have a huge disconnect between our medical model and our psych model, which Tina can very much help with that. You know, that's wonderful. Her service is great. And, but we need to combine that. And so, like, for example, I had a patient who, you know, she was a young girl, and she came to me with an eating disorder. And so we were working on that. Well, we started a medication, and one of the side effects of these medications is that it can make you impulsive, erratic, especially as a teenager. And so that was something where it was, you know, mom was talking to me every couple of days. She was checking in, and we were saying like whether or not the medication was working or not. And so that's what we need, is more continuous communication with the prescribing provider. We just don't have that. So you know, as a plug for me, for Tina and I, it's, you know, our services can be very beneficial when it comes to those kind of things, as far as what people need, and just increasing access and increasing that easy access, where it's a text message, where it's a phone call, where it's not calling somebody, having them leave a message and waiting 3 days to hear back. Those 3 days are crucial to what's going on in your life, and it shouldn't take that long. And so that's, you know, that's our frustration with the system. But these kind of services that are starting to crop up are people like us that are trying to fill the gaps in these care, and that can be very helpful.
That's excellent. Tina, did you have anything on that, or
Well, I
Molly,
was
go
going
ahead.
to say that would have been an excellent chance, that if your current provider is not meeting your needs, I always encourage people, ask for a second opinion, and it's okay. You know, if you're confused about something and you're not getting anywhere with your current provider, ask for that second opinion, because it may be that you need to hear, okay, they've exhausted everything, and ECT is a valid treatment option, but usually it's after you've done other things, they've been on other medications. And if they just tried one med and jumped to ECT, that's unusual. Although it has been shown to be very effective in older adults with chronic depression.
You know, as I got on Mayo Clinic and read on the website and stuff, I had, you know, first of all, it was hitting me in the face like, what, you know, but no, it was a situation to where it was a real eye opener to me about all the holes that are in the system. Okay. Because this particular individual went into a depression. We didn't realize he was. Then all of a sudden he tried to commit suicide. He admitted that at the hospital at 9:30 at night after he'd been there all day. And the nurse said, well, you don't have to worry, he'll be here for a while. We're evaluating him. I get a call to come pick him up at 9 a.m. because he was being released. And I'm going, are you out of your mind? They go, well, he said he wouldn't do it again. You know, I'm like, and then they just cast him aside. And that's when we were having all these issues trying to chase him down and what's going on. But no provisions of who to call, what to say, you know, I mean, it was like, good luck with that. You know, that was kind of what we ran into.
He should have been discharged. If they were going to discharge him, he should have been discharged with an appointment to be seen by a therapist or counselor within a certain period of time. And if that wasn't done, they kind of dropped the ball on that one.
Well, I think they did, but it was like 2 to 3 weeks or a month away when he was going to get seen. I'm like, no, we have crisis
Yeah.
today, so, but that's why I like to do these panels, because I like to get your voices out there so people know that there's life preservers out there. Is really what it comes down to, that you don't have to be out there adrift trying to figure it out. Molly, you were getting ready to say something. I didn't mean to jump in on you.
No problem at all. I was just wanting to add, I appreciate what I learned from both Farah and Tina, because we see the seniors that we work with, we see this treatment for loneliness and depression, and oftentimes being put on an antidepressant when the root cause of the situation is left untreated. And so what we help do is to define that area of root cause so that those questions can be asked to their healthcare provider. Oftentimes the resources are available. It's just there's this unknowing that, and this produces the gap that we're seeing sometimes. And as we all know, the mental health area is a growing area in our state and in our country, because the services have just needed to be more available, more readily available, and people need to be educated on what's possible for their health outcomes in that area, especially when we were thinking about our older adult population at this time during so much of the isolation. A lot of these conditions are being exposed at a more elevated level.
Now, when you're in the communities, you do most of your work within the communities as well, right? Now, are you doing it still through online, or are you back into the facilities as far as that goes right now?
We are in person in facilities at this time, and that is the Medicare approved program. We also have a distance learning program that's approved through the CDC. However, Medicare, our distance program is a self. All of our clients here, so they decide that to learn pre-diabetes, and they fit criteria. Make
I don't know if it's my link or yours that's cutting out on us here quite a bit, but so we'll just keep trying here in a second. But Laura, I want to go back to you.
I come back? Can you hear me?
Yes. I can hear you, but we're like freezing and stuff, so we'll keep trying here. Laurie, I was going to say, you were talking about palliative care. And
yeah, go ahead.
And that is something that I think that is probably one of the least understood areas out there, and what it is and what it does. And since we're talking about, alternative type medical things, that falls into that category. Would you kind of explain to people what that is and when it should be looked at, and from that perspective? Or
I think that's what's so funny about the knowledge about palliative care. It can occur at any age, at any stage of the illness, whether it's curable, chronic, or life-threatening. Palliative care is introduced to people that have chronic illnesses that are being managed, that are still seeking curable treatments at this time, and have a life expectancy of more than 6 months. So when you separate it out from what hospice care is a diagnosis of 6 months or less as a terminal illness. In palliative care, it could be at any stage of the illness that you are introduced to a team of support people who are helping with what you guys are, just the very things you're talking about, is finding support, finding resources, as having a nurse practitioner or a physician that would come even to the home. Hospice and acute care, palliative care are very different. I think people don't understand that it's not going to be like a home health type situation where you have all these people in your home many times a month. It's usually maybe once or twice a month that we see our patients. And then you offer social help and spiritual help as well, to help meet the whole encompass of the holistic the holistic person. We're trying to be a holistic approach to caring for and introducing to them the knowledge, the resources, and the things that they can do to be autonomous in how they care to be delivered. So we're trying to promote in palliative care. We try to promote these and open up the dialogue and the discussions about goals of care. What are your goals? Your goal may be completely different than your dad's goal or your sister's goal. And how do we define those? And getting people to sit down and have those conversations so that we can be autonomous in the case of your illness becomes the trajectory of your illness becomes to where you're less able to speak for yourself eventually. We want to get those goals outlined before that and give people that autonomy. It's a gift. It's a gift that you give yourself, is to make your own healthcare choices and decisions before someone else has to. And then in the meantime, what palliative care does is helps with those. It helps to provide a resource for people so they're not left wondering, what am I going to do? I'm out here. I don't know what to do. This is happening. But you have a number to call. We are a 24-hour service. So you have this number to call that helps you seek the resource, that can help you guide you through symptom management. The whole goal of palliative care is palliation, right? It's help to comfort and to give treatment that helps to improve the quality of life, to help improve each individual and their family's quality of life as well, because we offer, we want the family involved in that plan of care. We try to develop the plan of care that suits everybody that's involved in that patient illness and care. But again, it's end-of-life discussion, end-of-life planning, but it's also access to care, providing those resources, helping them to gain access, giving them access to a nurse practitioner 24 hours a day, early recognition of what those disease processes are doing and how the trajectory looks, and giving them that education and knowledge so that it's not a surprise. We don't have a surprise when dad starts with his mild dementia that this is what it's going to look like when it becomes moderate dementia. So we're just using that as an example, but we help start those education. We start that education early in the process. Hopefully we get the patient early enough to help get that done, but it's a needs-based care. And it's something that is, there's not enough of it. I think that's the whole problem. A lot of people, it's starting to open up more now. There's becoming several agencies that are providing palliative care. And I think hospital, they have the resources readily available to them in the acute care hospital palliative care situation, whereas at home, those resources kind of start to go down. So some of the hospice companies are providing palliative care. It helps prepare that patient. We have them at every age. It doesn't matter what your age is. The reimbursement for palliative care is becoming better. So I think that we're going to see better delivery methods of palliative care in the future. I think the reimbursement's been pretty shaky and pretty weak, to be honest with you. So a lot of people don't want to take it on because of that. We don't care. We're just trying to provide a service. So we use it as a non-value added to us, but it's a value added to a patient. So it's very much so not as confusing as what you tend to make it, but it's just about getting the education out there and to understand that you're diabetic, you can be on palliative care. You can work with palliative care, and we work with the primary care physicians alongside of those people with the primary care. We're just an added service. So, and some people choose to make us their primary doctor or their primary provider. And some people don't. They want to they can keep their specialists. We're not taking any of that from them. We're not doing as hospices. Hospice is for a end-of-life treatment. It's when we come to the point that it's futile to continue certain treatments or certain aggressive curative medications. Whereas palliative care, all those things still continue to happen. They all continue to happen.
What's the trigger point to say, okay, it's time to call palliative?
Palliative care can happen at any stage of the illness. Any stage of the illness, and the earlier the better, because we like to get people so we can help that education start early. So we have someone who's diagnosed with a heart failure or with a early stage kidney disease process. Anytime you're being given a chronic illness to deal with, we've had a palliative patient that was 14 and she had a rare condition that she was on palliative care for until we took her on hospice. But it's really at any stage of the illness. Once you've been diagnosed with that, it's a life-limiting illness. It's not a necessarily a terminal illness, but it's probably going to be a life limiting or a just a chronic disease that someone's going to be handling for a long time. The earlier you can get an extra support system in, is it's time to call palliative care. And again, it's just going to be some added base service that needs to work closely with that primary caregiver and any specialist, because one thing in palliative care we don't ever want to do is be confusing or to add confusion or to add treatments or information that's not cohesive to the other provider's information or so we want to get together as a team and say, we're adding this as a value to you as a patient, just to have another set of eyes. You know, I'm certified in hospice and palliative both care and in pain management. So a lot of palliative care patients are pain management type patients as well. It just tends to happen that way. But that's not all we do. That's not all palliative care is about. So I think it's just getting the education out there to let people at any stage of the illness, any age, whether they're still seeking curative treatment, it's just another value added service that's going to help to identify what their goals of care are. I really think that as a community, we've got to get better at defining goals of care. I need to know what my family needs to know what I want. And I think that we're so avoidant of the conversation. And those can happen with palliative care. Those can happen. And it's happened. And we are trained to do that in a way to make people comfortable about it. Let's be comfortable about it. We're not saying you're going to die tomorrow. What we're saying is, what do you want to happen? How do you want to live your life? You know, and if it's getting chemotherapy until their very last moment, then that's what it is. But let's define it. And let's see what we can do to make those goals come into fruition and to help as a healthcare team to develop a plan of care that's palatable to everyone, family, patient, most of all patient, but we always like to bring the family into. So.
Well, I'm sitting here as I'm looking at this screen and I'm seeing the different people here. I don't know if you guys have met each other before or not, but what I was curious about is how is the industry from you know, you guys are a representative. I don't know how representative as far as across the board, but as far as, you know, how is the teamwork between the different entities? You know, I'm sitting here looking right now and I'm sitting there going, I can see, you know, like FARA with the primary care position needing to be, you know, reaching out to, you know, these other different entities as well, and vice versa. Is that something that's standard within the industry, or is it something that is there a disconnect? Because I know as a consumer, I very rarely ever had good resources from one to another. Okay, so I'm trying to figure out how is that working to better that communication that says, oh, by the way, you need to be looking at this, or maybe, you know, this can add to your life. You know, Tina, I know that, you know, somebody's dealing with their primary care, they may be able to identify, especially if they're going to spend more than 6 minutes with them, you know, they might be able to identify, you know, that there's somebody there that has emotional issues that needs to be addressed. How do you guys, I'm not going to try to guess this, are you guys finding that works already in your world? What do you, and I think a lot of you are where you are because you didn't think it was working elsewhere. You know, so can you feed us in on how we can, as a society or a group, do a better job of getting that done?
Well, I was going to say, on one of the initiatives that we have here at ANC is the integrated healthcare model, so that we do have primary care on site as well as behavioral health care, and we work very well together. So, and we have an integrated staffing where we actually will talk about their medical issues and their mental health or psychiatric issues, and how we can make sure that we don't miss things and coordinate with all their specialists. So I had one client that came to me, she was very upset. And she came with her sister and she said, you're giving me all of these medications and I don't know what they're for. And she was living in assisted living. And so she brought me this list of 3 pages of medications. I look at it and I'm like, well, first of all, hello, I've just met you. I'm not giving you all these medications. Out of all of these 20 different meds, I'm giving you 2. But let's go. And I called and got all of her medical records from all of her specialists or primary care. And I sat down and combed through them. And I said, okay, so you're taking this medication and the record indicates it's for this. And this is the doctor you need to talk to. So go back and talk to your doctor about this. And this is what, and I made her a chart. And having the opportunity just to do that saved that patient relationship. So now she loves me. I could walk on water for her because I took the time out to just figure out what was going on and why she was on these medicines. Is because she's been in and out of the hospital. And so every specialist will add a medication and nothing gets discontinued. And this is what we see that happens a lot. So that coordination of care and being able to talk with one another is great. And the primary care provider here is right down the hall from me. So I just go down to her office and say, hey, we've got a mutual patient. This is what's going on. What are you seeing? Or I'll send her a message. And I've done that with outside agencies as well. I just got a phone call the other day, yesterday, from a physician from another practice, another organization that had concerns about someone's weight gain and their psychotropic meds. So we were able to collaborate on that.
Excellent. Anybody else want to get in on that one, or?
I think it's,
Sorry.
Sorry, go ahead.
Oh, I was just gonna say, I think that that's, what they're able to do is we really try to do that overall, in the traditional insurance-based kind of clinics, but, they'll have like a care manager, they'll have a nurse manager that can go in. When I was working at IU, we didn't have a nurse manager. However, we had pharmacists that would go over meds and things. I think the idea is that patients need to know that those are available so that they can say, well, do you have a pharmacist that I could talk to? Do you have a nurse case manager that I could talk to? And I think that's the biggest resource for people, is to know that these services do exist. And that, because I'll tell you, when I have 6 minutes with somebody, I'm not going to remember that, oh yeah, why don't you talk to this person, this person, this person? I mean, it will take 6 minutes just to explain all of that and then not even talk about their health topics. So I can tell you, with primary care providers that are saddled with patient panels of upwards of 4,000 people, they're not going to think about that. And so that's where all of these other people and like different organizations have been able to help patients advocate for that. But I guess the biggest advice to answer your question would be is learning about that these are options and they're out there. It's just a matter of asking your primary care provider and voicing that, hey, I need more than what you can offer me. Do you have somebody else that can help with that? And care coordination is really just it's a huge part of healthcare, because if you can coordinate all of that together and get a handle on it. I mean, for me, I have I tend to spoil my patients a little bit, because I had one that, I had to send her to a urogynecologist, and she came back. I goes, well, how did it go? What did they say? And she was like, I don't know. They spent 5 minutes with me. I don't really remember what they said. And I feel like nothing really happened. And so I requested the note. I talked to the triage nurse. I explained everything that happened to her. And she's like, okay, now I feel better. I understand what happened in the visit. So it's really just about that care coordination, and utilize your nurses, utilize your pharmacists, utilize all your allied health staff, and let your patients know the various staff that you have.
Well, I know for ourselves, one of the things that I would say that I most want in relationships is a quarterback that oversees all this stuff. Okay, somebody that's going to go, okay, this person, that person, we need to get them talking. We actually, with the seniors in my life, we actually have a nurse advocate that goes to all their doctor's appointments, keeps track of all their meds, what have you. And we still have troubles getting the coordination of care. We're going to way over another step, and we still, and we're still trying to find someone that will make sure that we stay on top of everything, because she's getting shut out of information from one group to another. It's one of those kind of frustrations. So we're exploring different doctors right now for that, so we can have a coordinator. Lori, just is palliative, is that something that they get involved in as quarterbacking, or how does that work as well?
Yeah, so palliative does do a lot of the quarterbacking. That is what palliative care does. But I think in answer to the other question that you were about the collaboration, and we're getting, I feel like there is a disconnect. I feel like it is sometimes like getting through hoops to try to collaborate with some of the especially older school. That the more Farahs of the world and Tinas of the world that we can get. Honestly, I no disrespect to our physicians, because I'm a very respectful to all physicians, but I think the nurse practitioners, if we could get more of those types of practices, that would be very engaging and very open to collaboration with other care providers to bring the best for the patient, then I think that that's going to be great. We do have several, we do work with several doctors that are pretty accommodating, but I still feel like there's quite a bit of disconnect, and thank you. I feel like there's quite a bit of disconnect in the relationships as they get so busy, they really don't want to take the time to communicate. But palliative care are definitely quarterbacks, so.
And I want to piggyback on Lori's comment. So thank you, by the way. The other thing I want to say is, for anybody who's listening, part of the reason why it's so difficult for us nurse practitioners to get started and start these businesses is because we have legislation against us. And so we need our patients. We need all of these people tell me, I love nurse practitioners. I love them, but they're not voting and they're not making the right choices and they're not advocating for us. So for us to be able to provide all of these direct primary care clinics, all of these various services, we need our patients and we need our people to talk to the legislative groups in order to lift our collaborative agreements, because it's such a minimal oversight for such a large restriction. And there are some physicians out there that will, and I love physicians too. I've got a great collaborative physician. She's wonderful, but there are some that will charge nurse practitioners upwards of $500 to $1,000 a month just to audit 5% of the charts that we prescribe on. So if you think about that, that is one chart a week, but that little rule right there inhibits a lot of nurse practitioners from being able to start their own practice and provide the amazing care that nurse practitioners can do. So get out there and vote.
Well, what are they going to vote for? What do they need to have? What needs to change?
I mean, there's legislative bills, there's going and just, I mean, even just talking to your legislators and getting them to understand how much any local legislation, anybody out there, state legislation, talk to them and let them know, even just a phone call saying, hey, I love my nurse practitioner and I really wish that she could open her own practice. And I wish we could lift those restrictions on nurse practitioner practices. I mean, even just if they were to get all of those calls in, they would start learning more about it, because I don't think that the legislators even have a handle.
Well, I'm going to tell you a little secret. I've done a lot of lobbying and they don't have a clue. Okay.
They have no idea.
And what I'm saying is they don't have a clue on anything, because they're looking at about 1,500 bills a year.
Yeah.
They don't understand any of them.
Yeah.
Okay. So that's, it was one of the most eye-opening experiences I ever did when I was doing some unpaid lobbying. I learned an awful lot as to how you have to learn to dissect things, get them to bullet points and deal with that. So you and I need to talk later, but tell me some of the bullet points, because I wouldn't be able to make a call now and say what to do, because I don't understand it.
Yeah, I mean, I honestly, if we were for the purpose of this forum, it would just be a call to whoever is your rep or your state representatives, all of those people, and just call them and say, hey, I want you to look into nurse practitioners and lifting the restrictions on their practice. I want more nurse practitioners in our area and being able to practice independently. We have full practice authority. We just can't practice as independently as we want to.
Okay, well, you and I need to talk about that later, because that's kind of stuff I kind of like doing. But anyway, so Molly, you're going in to try to keep people healthy in the communities, right? So tell me how do people find you? How do they learn what that's all about? How do you get in front of your clients, I guess is what it comes down to.
Usually we work with their wellness directors or the organization that they have behind keeping their people as well as possible in the independent living area. So most of the time we're advertised through the facility itself, through their wellness director. So I meet typically with wellness directors or executive directors of those organizations to provide this service. And our service is paid for by Medicare. So there's not an additional charge outside of that most often, unless we just have a large group in that facility that would like to have the service, but most of them are non-qualifiers, then we would work out a different agreement. But most often right now, our service is covered by Medicare. I also wanted to add, just to what has been said already, when we're inside a facility, we do advocate for them to go back to their healthcare provider, because what we find is we get a little snippet of what their health is based on our little time with them in a given class or over the span of the class time. But their healthcare provider has the whole picture of their health. So we refer back to their healthcare provider specifically. And like Farah mentioned and Laurie, their providers are nurse practitioners. Oftentimes they see a variety of allied health professionals. So we always say, whoever your healthcare provider is. And then with what Tina mentioned, we oftentimes will help them formulate some really good questions so that when they go back to their healthcare provider, they're asking the right questions to get answers to what they're really trying to accomplish for their overall health outcome. Thanks,
Excellent.
Jim, for that additional question.
One thing I was going to ask you real quick is if you're not in someone's community, how do they tell their community to bring you in?
We oftentimes send them to our website, Profound Health Solutions, and that tells the programs that we do offer. And then we're just, trying to get the word out that we're available to do those health education classes. And sometimes that's just visiting their communities for social interaction, social activities. So sometimes I just get their monthly calendar and come and meet the people that live there, and then offer our programming and do some cooking demos or some health talks to help them understand what we exactly do.
Well, very good.
Thanks,
Anybody
Jim.
have anything else you want to say that I missed to bring out that you need to have said? I'm going to give you a shot there. Before we do, let me go into a screen share real quick. I want to show you guys something. You can always go into Life's Copilot. We have these every 2 weeks, basically. So the one we did today, we have one coming up on palliative care, coming up on the 24th of August. On the 1st, the Alzheimer's Association, who is a member of Life's Copilot, is having their walk. And then we're going to do one on the 9th on how you can afford your senior care. On the 28th, basically Medicare's open enrollment starts in October, so we're going to be talking about that. So, and then we have other ones coming up. So I just wanted to share, you can always go into Life's Copilot. There's resources here where you can look at the different experts talking about things. You can go to the events here. So, so we just want you to be aware that that's available for you. We built that whole site because of the fact that we just got frustrated because people like yourself were not getting a voice. People didn't know that such things existed or how to find them. So that was really what we're doing here. So guys, thank you so much for your time and your expertise today. It was actually, I always am shocked that an hour goes by as fast as it does. Yeah. So, but does anybody else have anything else you need to say?
I don't think so. Thank you, Jim.
Well, thank you for being here.
Thank
Have a
you
good
for
day.
And
Life's
Farah, we need to talk
Copilot.
about that stuff.
All right.
Okay. All right. See you guys.
Bye.
Bye-bye.
Bye-bye.